So today we are welcoming back a frequent guest, our resident expert, all things COVID. He is the University of North Carolina, or is at UNC Charlotte with me, and he's the Carol Grotnes Belk Distinguished Professor of Bioinformatics and Genomics. And we are really excited to welcome back to the show Dr. Daniel Janies. So thank you for joining us again, Dan. We're excited to have you as we are continuing to navigate all of this changing world of COVID.
Yeah, thanks for having me.
You know, we reached out to you right away of just, hey, there's this new variant out there. And so we wanted to kind of pick your brain a little bit of what is the Omicron variant. I know there's been other variants that have emerged, some that emerged that there was nothing about it, and others like Delta. But what is it about this one that raised concerns? The WHO classified it as something special. I can't remember their categorization, but a variant of concern. So what does that mean? What can you tell us?
Well, what's interesting about Omicron is it contains 60 mutations with respect to Wuhan virus that emerged late 2019. And Delta contains 46. And what was interesting about Alpha through Delta is that you could see them in a lineage, in a nested set of mutations building, and each one was, incrementally more efficient than the other. What's different about Omicron is we don't know where it came from, and it's not really in those lineages. And of those 60 mutations, 37 of them are in the spike protein, which is the protein that the virus uses to interact with human cells. So there's a lot of open questions with respect to those, especially those 37 mutations in the spike protein.
So what kinds of questions? I mean, what is it that when you saw this in your team and other teams around the world, I mean, what kinds of things just popped in your head right away of what you needed to study or questions you wanted to answer?
The main thing is what do those mutations do to the conformation of the virus with respect to the antibodies that your body produces after vaccination and or after infection? And in our early computational predictions, we predict that the antibodies produced by vaccination will be much less efficient in their ability to neutralize Omicron.
Neat.
Exactly what we want to hear.
We've already seen this, with Delta, hence the breakthrough infections, and it's more the same. I mean, we expect more breakthrough infection. We don't know that much about transmissibility yet. What's interesting about Omicron is one of the key mutations that allowed Delta to be so much more transmissible and outcompete previous variants is also in Omicron, but it's in a little bit different. It's in the same position, but a little bit different amino acid change. So it remains to be seen what that means. Early data, very early data out of South Africa, where this has been going on since mid-November, shows that Omicron is starting to outcompete Delta, but it's so early that epidemiological data will take some time to come in numbers.
Is there any indication yet of how virulent it is, how dangerous it is?
The South African doctors are saying it's in the vaccinated. They are seeing breakthrough infections, but they're mild cases, just like Delta. Sort of summer cold, so to speak, and hospitalizations. That data even lags, even more. But hospitalizations are not yet up. For the unvaccinated, it could be much more severe. We just don't know.
Do you see that as the eventual trajectory of COVID in general? Is it going to go the way of becoming more transmissible but less deadly, so it just kind of settles in our population?
Some people think that's the case, and it's hard to predict how many more variants there are, since this one was not incremental, so to speak, on the others in terms of its evolution. There might be a lot more space, available for COVID to vary. And the problem is that we have the tools. We have, at least in the developed world, anybody who wants a vaccination can, or two or three, can get one. And people are not accepting it. So that leaves a pocket of people that Delta or Omicron in this case can use to infect and replicate itself and produce new variants. And so that's the situation we really find ourselves in.
If I may, I'm just curious. It was something I heard the other day on someone else was speaking about this, and so I'm curious. The first SARS that was detected, it spread, but not wildly around the world like this, right? And I know we talked in our original episode we had you on the distinctions here between SARS-CoV-1, SARS-CoV-2, but one of the things I think that the person said, and I can't remember the name right now, but what he said is that when a virus is more deadly, that may be one reason why it doesn't spread so much is because, or if it acts very quickly and kills the host quickly, that doesn't have the opportunity to spread like one that is not as deadly. Does that make sense?
Yeah. So you're talking about SARS-CoV. Some people say SARS-CoV-1 to distinguish it from SARS-CoV-2, which we're experiencing now. There was only about 800 cases, and it was much more deadly but spread less efficiently than SARS-CoV-2. And that's one of the harbingers of Delta is that it is outcompeting other viruses because when it infects you, it's replicating itself so much faster and it's getting out faster, and it's not causing symptoms as it's getting out of people, as people are shedding it. And so people are even walking around more and spreading it more often. It's making so many more copies of it than its predecessors too.
Okay. And so that's what makes this one just SARS-CoV-2 in general from the very beginning. It was one of the reasons why it spread so quickly is because we don't know we have it. Isn't that right? I mean, if we go back to the
ever more with variants. I mean, that was
okay, and now that's even more.
That was how Delta became so successful. It was spreading. Well, SARS-CoV-2 was spreading asymptomatically. Delta ramped it up.
So another question we have for you is, if Omicron does indeed show to be a milder variant of the virus, with less risk. Someone was curious, or we reached out to listeners, and what they were curious about is that if that is the case, does it make sense for it to spread throughout the world largely unchecked? This is kind of the whole, as you said, that there is a pocket of the population, especially in the U.S. and the world where we have easy access to vaccines, where people do not want to get it for whatever reason, the vaccination. And so some have said, we should just let it go unchecked. And so I'm just curious, is there...
Yeah, that was tried in Sweden early on. And conditions were somewhat different there. They have a lot of people who live in their own house by themselves and things like that. But it was a regretted decision because it was terrible for the elderly. You can have most of the population get a cold, but the people that are vulnerable, the elderly, the immunocompromised, people with other underlying conditions, you're subjecting them to a deadly disease in that case. And so that was.
So those of us who can get vaccinated, it's good to do that so that we slow the potential risk to others who are unable to get vaccinated. I mean, that's the whole point of vaccines anyway, right? There are those who are unable to get vaccinated for whatever reason, medically, in any kind of vaccine. And so they rely on those of us who can get vaccinated to do it so that they can.
Yeah, I think it's an interesting choice in medicine in that you're not only protecting yourself, but you're protecting those around you. And that's probably why, the argument's hard to swallow for a lot of people.
Right.
Yeah. I mean, if it came naturally to care about your neighbor, then every religion in the world wouldn't have to make it their number one rule. They would just do it. But it turns out it's really hard to convince people to think about other people's well-being.
That's an interesting way to look at it. Yeah.
Yeah.
So it seems like we are. It seems like we're getting more variants. Like we're just working up through Delta. I know out here they're still talking about this Delta wave. We've just hit the highest number in our county in the Delta wave, and now we're talking about another variant. Is there an accelerating impact in this, and is that going to are we going to see more quickly, or is this going to make it harder to end this waking nightmare?
We just don't know. And the big surprise of Omicron was it is so different looking. Most of its mutations are not shared by Delta, and so nor any other coronavirus, such that it really made us wonder several things about where it came from. And it's such a surprise, I can't answer your question. Maybe a month ago I would have said something, about the pace of variants, but this really throws a monkey wrench in all that.
Can you talk a little bit more about that? Like how do we get something that is so far out in left field that like a long lost cousin that we didn't?
Yeah, so it's definitely SARS-CoV-2. Okay, so it's not a new virus. There are several speculations, and I'll just preface this by saying there's no data for any of these that I've seen. I'd like to see some data, but much like Alpha, which was first called the UK variant, the speculation there was that an immune-compromised person had been affected with SARS-CoV-2, and the infection sustained itself in their body and was not fought against by their body, and therefore SARS-CoV-2 could vary within the person. I heard the metaphor the other day that situation's like an evolutionary gym, in which SARS-CoV-2 can get stronger and try out new tricks. So, and then it emerged from this hypothetical person. And then there was not much speculation after that for Alpha, and we saw the other variants becoming just incrementally better: Alpha, Beta, Gamma, Delta. The interesting thing about Omicron is that it is not connected to any of these lineages evolutionarily. Deep, very deep in the early emergence of SARS-CoV-2, we can tell it's SARS-CoV-2. And that brought up other speculations that SARS-CoV-2 from people went into an animal population, used them as this metaphorical evolutionary gym, and then reemerged into people. And this is not far-fetched. SARS-CoV-2 in the Netherlands, for example, and in Denmark, infected from humans, farmed minks used in the fur trade, and came back out to infect people. We know in the American Midwest that SARS-CoV-2 is somehow in white-tailed deer. They're not farmed; they're wild, but they're friendly and accustomed to people, especially in the American suburbs. So that still remains to be seen. Any connections there? Any evolutionary connections? And the third, which I think is more of you could say it's a third problem or kind of an overarching problem, which there's some debate in the surveillance community, is that we thought we were doing a great job, sequencing the heck out of SARS-CoV-2 cases, but maybe we're just not doing a very good job, and this thing was under the radar. It was first identified in Botswana in a AIDS lab, but then identified in mass in South Africa. But then once people had the sequence to key on, in the Netherlands, they found a bunch of cases in travelers returning to Northern Europe from South Africa, but then they went back into their yet to be sequenced samples, and they found they had early November or mid-November cases. So as we go back, we might find more about this. And we just wrote a paper, it should be out soon, where we review that there are many cases, many countries in the world where, even though we're doing a tremendous job in sequencing cases, you can do a back-of-the-envelope calculation that shows we're not doing enough to catch every variant. And so I think this latter scenario of just under-surveying, and it would be just a Herculean task to survey everything, but under-surveying is going to produce these things. And that could account for the animal reemergence case, and it can account for the the immunocompromised case. So under surveying is I think a blanket explanation.
Yeah, I've heard that those white-tailed deer have it in such large numbers in the places where they were testing it. It was like 75% or something I read, and that it doesn't kill them. And so it's like a little playground for them. And if it comes back, when I saw that article pop up, that was the first time in the past 2 years I felt legitimately hopeless. It was like, well, it doesn't matter how much we vaccinate. If the white-tailed deer population, which is all over my garden, is going to be carriers, then what hope do we have?
Do you want to address that question, Dan, or do we just?
I mean, you don't have to.
Yeah, it's speculation.
If there's no hope to be had, that's fine.
It's speculation. When it was discovered in white-tailed deer, nobody was talking about Omicron. So I don't know if there's a real connection there. There's a danger there always. Yeah.
So another question that emerged for us was, how does SARS-CoV-2 compare to other viruses in terms of how fast it mutates? And I'm sorry, I was looking off if this is related to what Zach already asked. I mean, there's not a set speed, or it just happens? Yeah,
it's relatively slow. The odd thing is SARS-CoV-2 didn't really mutate until mid-2020. I thought sequencing it would be quite boring. And then one mutation occurred, and people who pointed that out got quite famous, that because that mutation became fixed in all subsequent SARS-CoV-2 cases. And then we started to realize that mutations were building up, and this whole concept of variants really took off late 2020, early 2021. And then we realized, especially in the UK, that the variants were more efficient in their replication and thus their transmission. And then it got really interesting to start sequencing variants. But it wasn't a fast process by any means. You asked about comparing to influenza, which is a bit of an apples to oranges comparison, but influenza does not only in its own right evolve faster, but it's a different genome structure. SARS-CoV-2 is just one very long genome, whereas influenza has eight chromosome-like segments to its genome. So those segments, when a person or an animal is co-infected with two different lineages, they can reassort, it's called, or it's akin to shuffling a deck of cards and dealing out different poker hands. So it has not only the mutational avenue to change, but the reassortment avenue. And we don't see that in SARS-CoV-2 now, even though it's theoretically possible it could recombine with, but it's not as able to because it's not segmented like influenza is.
So with the mRNA technology that we have with at least two of the vaccines that are approved in the U.S., at least, what can be done with that technology, the mRNA vaccines, to be able to handle this variant or future variants, especially ones that could potentially be much worse?
Yeah. Well, the mRNA vaccines they can be just, in essence, reprinted. And the makers would like to argue that they can just reprint it and reformulate it and have it ready. I think Moderna said by March, so a matter of months. The regulators probably would want to do some and would be wise to do, clinical trials before it's used. So, it's really, the vaccine production's, almost immediate. But, I think there's going to be a regulatory period as well. They did start to make reformulations of the mRNA vaccines for Alpha and Delta, but it turned out the vaccines that we had, were already approved, or EUA at least, emergency use authorization, were effective enough. And so the question is, where do you take on a whole new regulatory pathway versus you have something that's still really good? I mean, we're going to talk about going down in efficiency, I think, in vaccine efficacy, in terms of Omicron and Delta, but they're still wildly good. I mean, a flu vaccine some years is only 30% to 50% effective, and nobody writes home about that. And so if we go from 96% effective to 75% effective for SARS-CoV-2 vaccines, even those directed against wild-type Wuhan virus, when applied to Delta or Omicron, we're still, in the black, so to speak. We're still doing pretty good, so.
Right. But they would have to, if something happened and, a variant emerged and, the current vaccines we have are not working very well, something needs to change. Obviously, they would need to go back through that clinical trials process again, right? Just like
I believe so. I believe they should, yeah.
Okay.
I mean, there might be regulatory regimes around the world where they don't, but.
Okay. But it's still significantly faster than what anything we've had prior to these mRNA vaccines. Like the process is still faster because of the technology that's available to us now.
Is it at all possible to anticipate future mutations and create future-proof vaccines?
Yeah, I've been thinking about that a lot. I think we're doing great as it is. But I think we could look at the number of possibilities for making a stable, spike protein and calculate those structures and sort of anticipate the function of them. I think the former part is easy. We can calculate out our structures. The understanding what they mean is a little harder, and the understanding what they mean, biochemically is a little harder, and then the understanding what they mean epidemiologically is even harder. So, we see this 30% reduction upwards of 36% reduction of efficiency against current antibodies by Omicron, but we don't know what that means yet, in the real world. So I mean, we could make computers run really hard, but it'd be hard to translate that to the real world. That's a great idea, though. I think it's something we should strive for.
Yeah. I mean, that seems like it would be easier if the viruses were progressing incrementally, like you said, but with something like Omicron that pops up out of the blue.
Yeah. There are many ways to skin the cat, and there might be a very large number of many ways that make an efficient SARS-CoV-2. And we have not, until Omicron, thought that way. Now we're thinking that way for the last 2 weeks.
How are there multiple ways to skin cats? I mean, isn't it?
I was wondering where that was coming from.
Yeah.
Pull it off?
I like the idea. Here,
Kendra's not here to defend cat kind.
Often the metaphor of a landscape is used. And so you have imagine a landscape of many hills, and the hills are optimal viruses, right? And it's sometimes thought it's hard to go from one hill to another. You can kind of like go up the hill a little bit. You can go alpha up to delta up the hill, and then when you're on the top, you're kind of stuck in one evolutionary space. But you got Omicron on this other hill over here, and so it's hard to imagine being less efficient to get more efficient. But what happens, I think, is that there's a set of contingencies. Certain mutations happen that allow others to happen, and therefore, evolutionarily, SARS-CoV-2 starts climbing a new hill, so to speak. And there may be many hills of efficiency out there, of evolutionary peaks.
Okay.
Can we go back to the deer situation? I mean, when you learned that it emerged or that it was detected in the deer population, what does that mean? Like for the human population and stuff. I mean, we talked about not really going away, especially since doesn't appear to be deadly to that population. But I mean, is it easy for it to jump back to us from them, or do we know yet?
We don't know. It's largely dismissed. I mean, the whole notion of zoonosis, I think, in general, is very important. We don't like to think of reverse zoonosis because we're clean and animals are dirty, but we're just another kind of animal, right? So we sometimes give bacteria and viruses to animals, and they're not being treated by and large, right? So the virus can live amongst them and evolve with them. And yeah, this is true. Influenza fundamentally comes from birds. We know all these coronaviruses, or many of the clinically important ones we're familiar with, come from bats. And that's the idea of a reservoir, that the virus is in the wild and every so often infects people, and then we pay attention to it.
That will always stick with me from our first episode. That you said the reason why these seem to come from bats is because bats have such great immune systems and nothing kills them.
And they fly around.
Viruses bounce around. And they fly around. What have you been thinking about in terms of this virus? What's interesting to you?
I really would like to know where it comes from. I mean, and I really think it's probably under sequencing, and I'm wondering how much, money and effort we're going to spend to deeply survey viruses. I'm not against it, but and we can do it. It's just a matter of political will. Yeah, I'm wondering where the political will is going to take us in a lot of these things. The president's already said we're not doing lockdowns. I thought that was the state's decision now, but I think this might be a point where we're going to just decide to live with the pandemic. Unfortunately,
it does seem that way. It does seem like I looked at cases the other day and was like, wow, this is nearly the highest single day that we have ever had.
Yeah.
And it looks like it did 3 years ago when I walk into Target.
Yeah.
And I was just talking with a member of my church who is, I forget her official title. I'm sorry, Amanda. But she's a bigwig in the emergency department of the local hospital, and asked her how things are going, and she said it's heartbreaking.
Yeah.
Like they've lost like 60% of their staff, and the outside world is acting as if nothing is happening inside. And so all these healthcare professionals are like, they're completely burnt out, and they've lost their faith in humanity, and they're done. And it seems like, all right, so this is the new normal. We're just going to normalize dying. And
so we can't live with
Merry
it.
Christmas.
We can't make doctors and nurses very fast. That's a lot of training, and it takes the right kind of person. And so maybe that's the response to this. We're just going to live with it because we have to have doctors, nurses, and everybody who makes hospitals run. So, and imagine all the ancillary effects. People are not getting their cancer screens, not getting their teeth fixed, not getting their surgeries if the hospital's full, right? Healthcare effects are going to be tremendous. We have a study here on campus of the adherence to PrEP treatment for HIV, and we've seen that gone down in the COVID period as well.
Well, I remember when Delta started taking off, we used to live in Louisiana, and there was a hospital system down there in Baton Rouge that talked about that the chief medical officer actually said that, because the numbers were so out of control there, that they talked about that something along the lines of that they were no longer an efficient system or something along those lines, because their numbers, they were so overwhelmed that they were trying to make it clear to people who were unwilling to get vaccinated prior to the emergence of Delta that even things as car accidents and stuff like that they would not be able to be seen because they were just that overwhelmed. And trying to send the message home to those who were adamantly opposed to vaccinations that the only reason why this is happening because you're not getting vaccinated, right? And so that's what they were trying to bring home.
Yeah, pre-COVID, there was already a crisis in rural America. Small hospitals were closing in towns that were not near big cities. So.
Right.
So don't get hurt in the country. That's for sure.
Yeah. Which was just, I remember when that happened when Delta emerged and it really took off, and I was hearing that, and I just kept looking at, my wife and just kind of saying that this is the U.S. Like, you don't think of stuff like that. So that's not supposed to happen in the United States of America, right? But as you just said, pre-COVID, rural hospitals were shutting down and medical care and stuff. But everyone always talks about, we're the greatest and we have all the best medical care and blah, blah, blah. But then we're turning people away, like doctors, which I'm aware that that's not the case. But, it was tough to hear again, to be reminded of the fact that this is not over.
Wealthy people and propagandists say that we have the best healthcare system in the world, but
right.
I think most folks would disagree with that.
Yeah, but it's just an interesting perspective being shared, and to hear again, chief medical officers saying we don't have the ability to care for you right now.
Yeah,
was very eye-opening.
So if you want to give your local healthcare provider a Merry Christmas, a Happy Hanukkah, or Kwanzaa, or whatever they celebrate by getting vaccinated.
Yeah. Well, and I remember, Dan, you and I were part of a panel, and it's still funny to think of this. I think it was like February of 2020, near the end of February, and it was before things really took off, and so no lockdowns were in place yet, and compared to now, very few cases were in the U.S. that we knew of at the time, and we kind of talked about in that panel about, and people were asking about, if this gets out of control here in the U.S., what about lockdowns and all that kind of stuff? And we just kind of kept talking about the acceptable level of loss. Like, and then I remember you pulled up a slide talking about the number of flu deaths every year that we were having at the time. And so that was considered an acceptable level of loss by society, not, an individual person, obviously. But it sounds like that may be where some are trying to go. Like, you see some just saying, I'm done. I'm not, this is over for me.
Yeah, I don't think it by design, and I don't think that's why I showed those slides. I don't think people really consider flu a deadly disease, but it is if you have the wrong underlying conditions, So now we've got another one that's, especially before we had the tools. There is some bright side. We do have tools now. We've had, influenza vaccines and antivirals. And now we're getting to the stage where we have, better vaccines than we did for influenza for SARS-CoV-2. And there are some new antivirals. I think that will probably be some bright side in the gloomy picture we've been, painting, that even unvaccinated people can take a regime of these antivirals and lessen their illness from SARS-CoV-2 infection.
Yeah. So thank you so much.
Yeah. Thanks, Dan. Is there anything else you want to share with us based on what you and your teams have been studying the past couple of weeks?
Yeah, I'll send you the paper. One is we predicted that, even though surveillance looks Herculean right now, that it's not. And we wrote that. And, we predicted, time will tell in the clinic, but we predict now that vaccines will be less efficient against Omicron than previous variants. So we'll see.
Okay. And we can link to that in the show notes.
Yeah, that'd be great.
All right. Well, thanks, Dan.
All right.
Appreciate you.
Thanks, Zach. Thanks,
Come
Ian.
on talking again.